thank you for joining us. Today we're going to be talking about, in part of our cancer care in times of COVID, the role of radiation therapy and how it's impacted our practice. I'm Kristina Mirbeau Beale. I'm a radiation oncologist in 21st Century Oncology in Southwest Florida. I'm in community practice, but I'm part of our breast program leadership. So I take care of predominantly breast and lung and palliative cases. And I'm joined by my colleague, Dr. Freedman.
Hi, I'm so pleased to be joining you here today. I am a radiation oncologist in Deerfield Beach, Florida, as part of the University of Miami Sylvester Comprehensive Cancer Center. I treat predominantly breast and head and neck, as well as some lung cancer patients.
Great, so I guess let's jump in. So how are you managing your patients with cancer during COVID, Laura?
Well, it's a changing world every single day. And we have a lot to figure out and work through, and we're holding a lot of meetings to discuss it. But as I mentioned, I treat a lot of head and neck cancer patients, and those patients in particular are much more of a challenge because these patients have significant secretions or tracheostomies, or we need to be examining their oral cavity and right in their face, if you will, which is the primary site for dissemination of the virus. So the care that's being taken, managing respiratory secretions, and in terms of PPE, the personal protective equipment, is really critical and completely different than what we were doing a month ago. And it's really changed our management. Treating a breast cancer patient is less of a challenge in the current environment, but still all patients need to be treated as a potential positive unless we have a clear negative result on a test, which, as we all know, are hard to come by. And although I've stopped, for instance, looking in the mouth of a breast cancer patient just to minimize any potential exposures, you still have to be careful. And I don't know about you, but I never used to use gloves to examine a breast. I felt as though it minimized my ability to really feel changes, but all patients are having examinations with gloves now.
Wow. So I'm curious, are you also doing fewer scopes or just as many, or do you have adequate PPE to be able to continue your normal practice?
I have really cut down on the scopes. The scopes themselves are a particular concern. They're increased risk for transmission, and unless it's very critical, I'm holding the scopes, and I've had that conversation with my ENT colleagues who are also minimizing their scopes, and in particular, requiring additional equipment. For all of my head and neck patients, even for simple exams, I'm also now using a face shield.
Wow, good. So kind of at the
And
other
an
end.
N95 mask, which has been hard to come by.
Wow, so that's great though that you guys have adequate N95s.
We just got them.
Kind of, I guess, at the other end of the spectrum, I'm a generalist in a high volume community practice. I do mostly breast and also lung GI malignancies. And I think it's interesting kind of having to introduce this concept that not every cancer diagnosis has the same degree of urgency, especially as we try to convince our patients, like our early breast cancer patients, for example, that it's okay that their surgeries are being delayed and that they take an aromatase inhibitor for, our estrogen positive postmenopausal ladies. Because especially, I think there was just this very awkward transition as the pandemic kind of came to light, where folks were saying, but I just got the screening mammogram, I had the biopsy, you told me I have cancer, this needs to be handled right away, and now you're saying I can wait. So there's a lot of anxiety, I think, that comes with kind of managing that. So I think there's both the, kind of higher risk cancers, the ones with high secretions, exposure risks, or head and neck, et cetera. But then there's also this intense psychological piece, I feel, for other cancers, and kind of how we're recounseling our patients who sometimes feel, I almost think they almost feel forgotten, that they're kind of being told to put on hold when, for them, their cancer is very real, and it is for us as well. But how we're prioritizing the infection risk, I think, has definitely changed the mindset kind of in our clinic.
Absolutely. And I had two patients come through recently. One was an early stage breast cancer, hormone receptor positive, and one was a DCIS. And typically they would have already started and how and when to get going in the setting of the potential risk for infection is a challenge, exactly as you stated, for myself and balancing for the patients, but also for them and their emotions and their anxiety. I agree 100%.
So what are your greatest concerns in standard of care delivery outside of things like PPE, which I think you'd already started alluding to?
So I think the number one concern for all of us is PPE, and I have to highlight it, even though we are saying outside of that. But jumping back to what we just talked about, it's making sure that the patients can still be treated in a timely manner so that they can be cured. And it's that balance between the risk of bringing them into a department where they could potentially be exposed to something and the benefit of getting that cancer treatment going. And we, as we've discussed, and it's probably the same situation with you, we are having policies and guidelines change every day. As soon as the flow sheet or the guideline or the practice model comes out, it's being reissued. And so since I turned in my information to help put together this presentation, we have now determined that all patients who are starting treatment in our facilities, either chemotherapy, radiation therapy, or going for a surgery, have to be tested with a negative result, theoretically, before they can come in for these tests, procedures, or treatments. And so right now we're really caught in the middle because I have patients who are due to start on Monday, but this just rolled out 48 hours ago, and you have to have the opportunity to get a test and have the test resulted. I also work off-site, meaning our mothership is in Miami and they've been testing there, but the testing is not available in Broward County until the end of next week. So where do we draw the line? How do we balance out who can continue to wait? How do we bring in the rest of the team members to contact the patients for a test, to get it scheduled within our testing community, to get a test result on time and verify that we've had it? There are a lot of extra steps that are being taken in order to proceed with the treatment that we never had to do before. So that's been a real challenge just in the last few days, with a lot of additional meetings and now reaching out to the patients to have this testing performed. Additionally, we're experimenting now with telehealth. I don't say experimenting, but it's new. I had never before a week ago performed any sort of virtual medicine evaluation. And given the fact that it's challenging to bring a patient in, we in particular in my clinic, I work in an area where we have a lot of elderly patients, and they're at greater risk for complications from COVID-19. And limiting their exposure in our clinic and limiting them coming out of their house is really opportune. And so we are balancing this with telehealth. And when we're doing telehealth, there's a lot of new challenges. I can't fully examine a patient. I cannot palpate a breast. I certainly can't do a scope via telehealth. And I don't want to miss anything critical on a physical examination. What if I'm missing an axillary lymph node? What if I'm missing a supraclavicular lymph node, or feeling a tongue-based tumor? So in addition to just the challenges that people have with the electronics of it, it's a new process, making sure that everyone can log on properly and see what needs to be seen or hear what needs to be heard. It's amazing that we're in this technological environment that we can really do a fair amount via telehealth, but the process and the limitations on the physical examination are certainly challenging.
I agree wholeheartedly with everything you said. I think I'll deviate from my slides only because something you made me think of is I also feel like as these guidelines change, we almost kind of rethink our sequencing of different treatments. For example, I saw this lady earlier this week who's 91 and had, really it's a gastric cardiac adenocarcinoma. And her surgeon sent her to me thinking, well, she's 91. I think she could tolerate the surgery under perfect circumstances, and normally we would take a gastric cancer to surgery, but we're concerned about putting her on perioperative chemo given the risk of being immunocompromised. We're also concerned we won't be able to get the surgery done because we're trying to scale back our operative volumes given our current inpatient status. So maybe we should think of her as an esophageal and try to just get her on the chemo radiation so she's doing something. And I had to really kind of advocate that, I'm worried about the risk for this lady coming back and forth through my department for 5.5 weeks for daily treatments. That has implications as well. And it ended up being this really rich discussion where we kind of came up with a compromise regimen of her doing a neoadjuvant chemo regimen we thought would be a little more gentle, and then biding time for about a month or so to see if hopefully she can get her definitive surgery. But it's this kind of discussion. I think we have the data that we follow to guide our management, but in times of COVID, in some sense, all bets are off, and you kind of have to think practically what limits the exposures to the patient, but then also doesn't compromise their oncologic outcome. And I think that's something I'm wrestling with. I'm because I think, especially in a time where now we're aware of community spread, and it's really just a matter of mitigating risk, but not so much containment as it was earlier in the pandemic. I think that's going to be how we can hopefully eventually move forward some of our procedures that have been on hold. And I think our community is still trying to navigate that because we don't have as widespread testing. And then I'll add to, obviously the limitations in terms of kind of telehealth for physical exam. There's also a limitation in terms of the emotional support we can kind of offer our patients in some of the more trying aspects of their journey. So, giving bad news on a scan, for example, explaining to a patient why they need to come in physically to start emergent treatment. I think the telehealth platform is great in that you can be accessible kind of more frequently or more readily in some sense, but there's a limitation in that human connection. And then also there's the technology limitation for a lot of our patients. And I think a lot of added frustration of trying to log in and not being able to. So it's just really affected our clinic, in some ways good, but in some ways that we're still kind of figuring out.
Yeah, although it was interesting yesterday, I did a visit, and we are no longer allowing anyone into the department who is not actively receiving care, which is really sad for some patients. They're older, they need help. We've got a wonderful concierge team that will bring them in a wheelchair and help them. But, for patients to sit in the chemotherapy area for several hours all alone, or even just to come in for radiation and have a conversation, either during a consultation or a weekly management visit where we're discussing the challenges and the side effects and how to manage them, and they're alone, that extra set of ears is missing.
Yes.
So I actually had the opportunity yesterday in a telehealth visit to have the patient's wife present. And she was taking avid notes. She was asking the questions. I could tell that it was actually much better for this patient because it allowed me to have the support and additional ears and additional questions going on that were allowable with a telehealth visit. And, sometimes the patients will call somebody on the phone, but we can't hear them, and we've got poor cell reception. So it was really nice that the family members could be present, whereas they cannot be present in the clinic currently.
Since these challenges are not one size fits all, what are you personally doing differently?
So as we've discussed, telehealth is something that's completely new to me. The precautions that we've discussed in terms of PPE, which has changed again weekly. I started off with a mask, and then I added a face shield mask, and then I had the opportunity to get an N95 that I then cover with the face shield mask. I found some goggles. I wore a gown, PPE type gown for my head and neck cancer patients, and every week I sort of have added a layer. But I've really added the telehealth to my practice, and I'm working to increase the number of visits that can be performed via telehealth to minimize patients' exposure, my department's exposure. So it's a nice sort of opportunity to balance out delays, at least in the visits, and determining what can be done next. And beyond that, it's that challenge of delaying patients, these low-risk patients, as we mentioned earlier. Typically we just treatment plan them and put them on our schedule, and it's figuring out exactly what is the right time. And the numbers and the graphs and the projections change daily. So we're trying to balance, where might the peak be? Should we get them in before a peak? Should we get them in after the peak? But then the projections change. So that careful balance between when it is appropriate to start a patient and when we should hold a patient is a challenge.
Absolutely. I'm curious, what are your therapists doing? Do you have a protocol in place in terms of their protective gear?
So we do. Again, it changes daily, and I have to really praise my chairman. My chairman has been very proactive at the safety of our entire department, and he was able to accomplish getting N95 masks for everyone in our department. literally yesterday. So
Wow.
as of yesterday, my therapists all have an N95 mask. Unfortunately, they have to wear it for probably 3 days straight, which is not the way they're intended to be used, but I'm really pleased that they now have the opportunity to have an N95 mask. They certainly have the most contact. There is definitely no telehealth radiation. They see these patients every day. They're in close proximity to them physically. And everybody in the department has been wearing a surgical mask, but as of yesterday, everyone has access to an N95. They are certainly wearing gloves. They do excessive cleaning with all of the appropriate Sani wipes that are going to clean for viruses and the time that's required for them for the drying. And anybody who, luckily we haven't had very many, but anybody who is a potential positive, it's recommended that they're moved to the end of the day and that additional protective equipment is utilized.
So we have very similar procedures. There was an interesting New York Times figure that looked at different occupations and stratified them based by exposure risk. And radiation therapists were kind of at the high end of the graph in terms of high risk exposures, along with kind of dentists, oral surgeons, people who do aerosolizing procedures regularly. So I think it's very important not to minimize the risks that our therapists, who are kind of in the face of the patients, lining them up day in and day out, can have. So I think one of my challenges, or things I'm doing, again, like we talked about, kind of aggressively trying to stratify patients in terms of, who we can safely delay their treatment versus who needs to start treatment right away. And that definitely has been kind of adjusting the framework in terms of folks who think all cancers are urgent and their cancer is still very important, but it has to be weighed against the risk of the daily exposure of radiation, or not so much the daily exposure of radiation, but daily exposure coming into and out of the department in times of a pandemic. And I think, as I mentioned earlier, we kind of had a bolus of patients who had just had their surgery and were just in the thick of their workup and expected to start normally kind of at the beginning of March. And that was kind of a chaotic period where, when our community had very little or no known cases, at least known cases, because obviously testing has been a limitation, who just kind of said, can I just start and get done, because I'm expecting this will get worse as time unfolds. And so, navigating that, is it better to start treatment and finish it before the surge versus waiting until 3 months from now when we're not sure how this would unfold? And then something else I forget if we touched on also is just dose schemes and trying to hyperfraction aggressively where we can.
I think that was coming up, but I don't remember.
Oh, maybe it is. Well,
yeah.
Come get up.
And one of the things that I was just going to say, one of the things that I've noticed also with my patients and bringing them in is, it's not just about exposing the patient, but if the patient by some chance got exposed, even if it's just that they're going to the gas station to get gas because they need to drive for radiation, they could bring something home to their family. And I have a patient whose spouse is a transplant patient and they're immunosuppressed. So even though my patient might be just fine, the patient could bring something home to a spouse who may not be just fine. So it's not just the risk-benefit ratio for the patient, it's the patient's entire inner circle.
Absolutely. And I think, especially since we're an outpatient setting, the surgeons had been more proactive earlier on in terms of kind of slowing down elective surgeries because of the need for not just all the surgical masks on deck, but then also potential for needing the ventilators and minimizing exposure in that setting. So I think, as an outpatient specialty, we really had to rethink, all the different touch points that having a patient go through daily radiation really introduces in terms of, kind of being counter to staying at home. And we have to really do that risk-benefit ratio to make sure it's worth those potential risks, not just to the patient exactly, but to their families, et cetera. So I'm not doing great with this either. How are you managing work-life balance with the new considerations like, a spouse working from home, children home, homeschooling, all the shelter-in-place rules that have kind of evolved and changed dramatically?
So I'm lucky because my children are a little bit older and they're relatively self-sufficient. And I recognize that because I certainly have colleagues who are trying to work through and become themselves IT support for their children who are trying to log in to a number of online programs. But I'm doing my best to continue normal schedule without any other issues. I am still going into the office at least 3 days a week, if not 4. But I'm the only one seemingly waking up early. So whereas my son was typically up at 5:30 in the morning, and I was up by 6, and my husband was up, and we were all out the door by 7. It seems as though when I'm walking out the door at 7, the house is completely quiet. It's
Must
also,
be nice.
I have the opposite time frame because my college-age children came home from college, and college-age children work off of a different timeline. As my son told me, 3 a.m. is the new midnight.
Oh, geez.
And he's up playing video games until, no joke, 2:30 in the morning, right next to my bedroom. So that's not something I was dealing with a month ago. And I have to remind him to be quiet and to respectfully be aware of me in the house, that I need to leave. And we've got 5 of us on laptops using the internet, trying to balance things out, closing out the extra noise. And one of the biggest problems I'm challenged with working from home is the lack of proper computer. I have a small laptop. I don't have a second screen. I've got my son, who's a computer whiz, hooking up a spare monitor so that I can have 2 screens, but it doesn't seem to work all that well. It just, everything is a little bit more challenging, in addition to all the extra meetings that we seem to have.
Mm-hmm.
But it's a balance. I'm a person who wears a dress to work every single day, a dress and heels, and I have had to find scrubs. Luckily, my colleagues in Miami were able to find me scrubs. I hadn't worn them in about 25 years, but I've switched to wearing scrubs to work. I come home from work and I change clothes in the garage, immediately drop the clothing into the washing machine and head straight to the shower. Mm-hmm. I'm doing the best that I can to minimize contact with patients in the clinic and to be completely gloved and face shielded and masked and sometimes gowned, but I'm still coming in and taking every precaution possible to leave any exposure behind and immediately washed. And I leave my shoes that I wear to work in the garage. Mm-hmm. Completely different than anything I ever did.
Well, let's see. So similar situation. My husband's an orthopedic surgeon, and he takes trauma call, but he's mostly a predominantly sports medicine physician. So we have our decontamination station in the garage, where we basically strip down to our undies, shoes off, leave that in the garage, Lysol that after the fact, and then run in and take a shower, wash face. I make sure I don't wear any jewelry basically anymore to work.
I gave up my jewelry.
Exactly. Things like that, shoes stay outside, and then compulsively Lysol them. Though the shoes Rothy's are great now because you can just machine wash those as well. And, so there's that piece of like this fear of wanting to, minimize exposure as much as possible to not put, my elderly parents and my children at risk. But then it's been interesting navigating our relationship, because as a dual physician couple, I think my husband felt very useful as a surgeon. And now he kind of feels on the sidelines in some ways, because all of his elective cases, which is the bulk of his practice, are on hold. And there's this feeling of kind of wanting to be more on the front lines and managing having all this extra time at home and not really constructively knowing how to deal with it. Whereas, our balance has more been, I was part-time, now I'm full-time, but just obviously less demanding kind of hours than a surgeon per se, but cancer didn't slow down and my practice is just as busy. So it's been kind of a role reversal for our family that we're still navigating. And then after that, my kids are at the other end of the spectrum. I have twin boys who are 4.5. So
who's managing your children?
So it takes a village. My mother lives locally and helps a lot. But then I also worried about her in terms of exposure, just because she has no health issues, fortunately, but she is, in her 70s. So she basically is just allowed in our house. And my kids haven't been out basically in almost a month at this point. I also have a nanny who's outstanding and kind of helps with the house management piece and watching the kids day to day, especially since I have to be in the clinic. And then there's that added piece of kind of enforcing social distancing for her to try to minimize touch points. And fortunately, she's really committed to kind of supporting us and our family. But, I definitely kind of had a lot of sleepless nights thinking, gosh, when my husband's on call and I too have, infection risk day to day, like what's going to happen? What happens if one of us gets sick? Where are we going to isolate? How does this affect our childcare? Um, and, we just try to take it day by day. Just like you said, Laura, you do as much as you can to minimize your individual risk kind of in your day to day and hope that everything will be resilient as possible. I feel for my little kids though, because my boys are so young, they don't really understand why they can't go out and see friends and all that sort of thing. So,
it's interesting though, because my parents are in Florida for the winter and they're in their 70s. And unfortunately, my mother is going through chemotherapy. So she's immunocompromised and at risk, and she's coming through my facility, but my dad can't come in anymore. So I'm going and visiting her briefly. And I celebrated my birthday last week, and my parents kept begging to come over, and we finally let them in the backyard. But I'm so afraid to inadvertently expose her to something that we stayed very far apart. I couldn't hug her on my birthday. And my father doesn't seem to get the risks either. So even though he's an educated physician, retired physician himself, I think that, when you start to approach 80, things just change, and the comprehension of everything that's going on is also a little bit lost at either extreme of the age.
Mm-hmm.
And it's challenging because they're here and we've started grocery shopping for them so they don't have to go to the grocery store, but it's a very limited exchange, setting bags on the driveway and stepping away.
I very much wrestle with that. I think, I was able to have kind of an honest discussion with my mom. We lost my dad a couple of years ago to cancer. And I think that she understands some of the risks. She, literally just stays in her condo or comes to our house. But for us, the decision-making of allowing her to even kind of be intimately in our household when we're a two-physician household was stressful, but we decided to just go for it. I worry about it with my kids because just other doctor moms, especially when both parents are kind of on the front lines in some capacity, have made choices to, for example, kind of either send kids away or isolate from their children. And I haven't been able to do that. And so I do the decontamination and I try to limit certain things, but otherwise when I'm home and once I've done my decontamination shower, I'm in mommy mode on the floor with them. And there's always that little bit in the back of my mind, kind of like, I hope I'm not putting anyone at risk. And it's just made an already stressful job and a stressful time. I think that's the piece that is so kind of heart-wrenching of this pandemic. It kind of separates you from your support system,
Yeah, and it's interesting because I can't even imagine what it would be to have a two-physician family and a husband who's going in for trauma call or something where it's so unpredictable and you wouldn't even know, and you wouldn't have the opportunity to get a test, and you'd have to potentially have a significant exposure to save a life or something. But it's interesting because my husband is not medical at all, and he has been going into his office because their platform is really linked to the office and their servers. And it's a small office, so you think it's quite safe. It's just really 3 or 4 of them in there at a time in total, and they have their own office space. And yet, one of his coworkers, his daughter tested positive. So, you think the exposure is much greater in the health field, and yet his coworker's child was positive, so his coworker was absolutely exposed.
Mm-hmm.
And you start to think, well, that's not the person who should be exposed.
I mean,
but
they're not wearing N95s, right? I mean,
right, they're not wearing he doesn't have a mask. He doesn't have an N95. And luckily the coworker said, oh, my daughter's not feeling that well. She just come back from college in New York. I'll express extra caution and hold off on coming to work for a couple of days. She got worse, got tested and tested positive. So thank goodness he didn't come in. Because he clearly was exposed, and it was in no way a healthcare situation.
I think in that sense, moving towards kind of more of a universal precautions attitude will hopefully allow us to kind of streamline some of the processes around containment and quarantine so that folks can feel like they can be there with their families and not be as paranoid, but who knows? Maybe that's just pie in the sky. I'm not sure. So I guess that's a good segue. What is one positive thing that you're hoping to take away from this crisis?
Well, gee, I think that we've learned how, oh, this is yours, actually.
Oh, did you not answer? Well, answer still. I want to hear your answer.
Well, I think mine might be next. Go ahead and we'll see.
Well, I am an optimistic person, and I think that hopefully this can be a time of clinical innovation. I mean, especially since things change day by day. I think we've had to really work together closely in our department, you know, putting together the different stakeholders to really make sure that we're evolving and staying timely and doing what's safe in terms of best practices for our patients, for our staff. So in that sense, I'm optimistic. I think strategic use of telefollow-ups, especially, our clinical practice is such that we have several sites that are kind of geographically disparate, and kind of rotate through. And so sometimes, you know, if I'm not in, you know, East Naples until the following Monday, and there's a Monday holiday, there would be this 2-week gap before I could see my patients again. They'd have to be covered by another physician. Now, if we were able to still integrate some of these telefollow-ups, potentially you can be more available to your patients, even if you don't rotate through a particular satellite clinic for whatever reason. And I've just been really impressed by the camaraderie that kind of has bonded our department together. So, you know, I'm hopeful that as we kind of adopt this, we're all in this together. Let's try to figure out best practices kind of mentality that can translate even after the pandemic into us just improving our processes and trying to make sure that we are, you know, not blindsided again in some ways.
Oh, so maybe I did not answer. I'm not
Right.
certain, but I would echo everything that you've stated. I think that the ability to use telehealth in the future is certainly critical. And, you know, even the terminology of clinical innovation, and I think, I guess, jumping back to what we touched on and thought was in there is the idea of how can we manage the treatment plans in an opportune way to minimize patients coming in. And that is, as you were stating, shortening a course of treatment, using a different regimen or fractionation to accomplish the same goal, but minimize the number of times that a patient is coming in for treatment. And I've also been very impressed by the way the radiation oncology community as a whole has come together. The various Twitter handles and universities that have very thoughtfully put together guidelines for different fractionation regimens that have been published across the internet and forwarded and sent to the Astro website, so that we all have really some cohesive guidelines to utilize to help us out with what can we do to minimize the number of times a patient comes in, how we're expanding the use of hypofractionation even in the post-mastectomy setting, where it's typically only done on protocol right now, to say this is an acceptable regimen and this is an arm on a current trial, and we feel very comfortable with its use in other countries, that right now we could really cut the amount of times that a patient's coming in almost in half. And that really can make a difference in their exposure. And it's their exposure and the exposure of our therapists, as we were saying, because the less times that the patients are coming in, it's the less interactions in general. And I think that it reminds us that we can always be reinventing how we practice in manners that may be optimal or even better for patients.
What's something important to you now?
My family is super important to me right now, and that's why I want to protect them. As I stated, my mother is going through chemotherapy, so I want to make sure that she's safe and taken care of, but yet doesn't feel lonely while she's going through treatment. And, we already discussed this, but being careful to be able to have some sort of interaction, but a safe interaction, so that I don't expose her in a manner whereas she could be sick, not from her cancer, but from COVID.
Family. I completely agree. And in that sense, this pandemic has really kind of strained, it's a religious weekend for, Jewish and Christian faiths, and we can't have community and family celebrations in the same way that we would have. I think there's a lot that we probably take for granted. My husband and I moved to Florida to be close to both sets of parents. And even though we wanted to be close to both sets of parents, in the rigors of having two careers and young kids, we sometimes didn't make the time to really just, take that long weekend to go visit our families on the other coast. And now, when nothing like a travel restriction to make you realize all the travel you wish you could have and should have been doing.
Yeah.
So I think there's that. There's also kind of thinking of your own mortality and kind of your own limitations and the contingency plans in our childcare. That's something that's very important to us now in a way that I don't think we had kind of concretely looked at in the face. And then also, I have a lot of close colleagues and friends that maintain connection with that are in New York and Boston. And I agree with you. I think our professional organization, Astro, has been great about not just kind of rallying the community around looking at kind of more broadly accepting different regimens with hypofractionation. I think publishing like the experience in Italy and Wuhan in terms of, how those clinics were able to navigate being at an epicenter, and then, illuminating some of those best practices so that we could stay kind of ahead of the surge in terms of managing our clinical output. So I very much appreciate that sense of community with family, with colleagues. It's just been really
it also trickles out to not just us working in the medical field, but to family in general. Very unfortunately, my husband's mother passed away yesterday. And so she's in Michigan. And so not only can he not travel to Michigan, there's really no traditional funeral, and they only allow 10 people to be 6 feet apart at a graveside funeral, which isn't even enough for the family members that are present in the state of Michigan. And we would traditionally hold Shiva, which is the opportunity for friends and family to call on a mourning family to help them grieve, but also to remember and to celebrate the life of the loved one. And that's really important in the grieving process. And he can't do it. We can't go to Michigan and we can't hold a Shiva. And it just really puts a lot of things in perspective and reminds you of the value of your family in the here and now and the challenges that this is providing on so many levels.
I think we addressed some of this. What are some of your COVID-19 takeaways that you'd want others to know?
I think first and foremost that we've all said, and we see it everywhere, safety first. We're going to get ahead of this by using the appropriate protective equipment and washing hands and staying apart from each other. Love is so important on all levels: family, friends, community, professional community. Safety first goes back to all the washing of the clothes, the masks, your sanitation station, and that there are ways to work around this and get around this and still give quality medical care, such as with telehealth and the shortening courses of radiation that we've discussed.
I agree. So just more acceptance of shorter courses of radiation. I think more thoughtful collaboration with our chemo and surgery colleagues in terms of sequencing treatments for patients. Being very individualized in our approach. I think safety and hygiene, as we've talked about a lot, and then obviously just not taking anything for granted.
Yeah, I think it'll be interesting once the world sort of goes back to normal, if you will, how many of these things stay with us. Will we have a handshake with a new patient or an old patient? Will we wear more masks? I think it'll be very interesting to see how things evolve in the future.
Well, thank you, Laura. I think this was a great discussion. I learned a lot in discussing things with you and hearing how your practices approach things. So I hope we can remain in contact during all this and beyond.
Absolutely. You are a wonderful partner. I learned so much from you, and I appreciate how you put this all together and moderate it.
Thank you.